Welcome back, you guys, to our webinar series. As you know, we are the OCD Institute of Texas, and this is In Session with OCDI. We use these webinar series as a way to educate, provide some resources, hopefully tools, and most importantly, a lot of psychoeducation around the treatment and, of course, the history of anxiety disorders and OCD. My name is Dr. Elizabeth Mackingveld, and I'm the director of our program.
And I'm Ryan Judd. I'm the clinical director here.
Yeah, so we're excited to hop in. Today, we're going to talk all about anxiety disorders in clinical practice. It is IOCDF, the International OCD Foundation's conference weekend. So, of course, we are here in Seattle. If you are here and around this weekend, please come say hi to us at our booth. You can find us at OCDI. And as always, we just appreciate you guys taking the next 45 minutes to an hour to spend time with us learning together. I think the fact that you guys are attending and watching and live with us and asking questions and all the things just really shows your dedication to treatment and to making sure that you're understanding the treatment you're doing, that you're talking appropriately about the treatment that you're doing, and that's what we're here to do. So you'll never hear any of us speak about things we don't know, we're not trained in, we're not competent in, because that is not the point. The point of this is that we want to bring real education, real advice, real feedback that's rooted in evidence-based care through appropriate research. So here we go. Today, we're going to talk about anxiety disorders. We'll talk about the assessment, formulation, and treatment strategies. And of course, a couple webinars that we've done so far have covered CBT. They've covered exposure and response prevention. So we would encourage you, as always, a lot of what we talk about is going to be rooted in CBT and like the theoretical foundations and understanding of cognitive behavioral therapy. So if that's something you feel like you need to brush up on or you don't feel super well versed on, please go back and watch one of those webinars first, because we think it's just so important to have that foundation.
Absolutely. And just as a note, our webinar in the clinical series In Session for next month is going to be kind of a continuation of this topic. It'll be anxiety disorders. However, we're going to go into much more detail about the actual specific interventions. We'll talk some about interventions today, but we're really talking more about kind of the initial assessment, diagnosis, differential diagnosis, and kind of case conceptualization. And so we'll go more into kind of interventions, micro interventions, specific interventions, disorder specific interventions in the continuation of this in next month's edition. So we can go ahead and get started.
And of course, if you guys have questions, feel free to put them in the questions and comments pane. Otherwise, you can also private message us and we'll do our best to answer those both throughout today's session, but also, of course, at the end. And any questions or comments that we don't get to, we do take those, we kind of catalog them, and we do our best to answer them in our next webinar.
We're going to be talking about the CBT's theoretical conceptualization. As Liz mentioned, we've talked about this before, but I think you'll really get to see it in action as we use a couple of different disorders that we're going to talk about today, how that looks in terms of CBT's theoretical formulation. We're going to be talking about kind of the most common anxiety disorders that patients are presenting with when they come for treatment or they come looking for therapeutic services. The kind of basic assessment tools that we might use when we're trying to gauge both diagnosis but also severity of symptoms. And that can also help us gauge level of care, the right fit for the intensity and frequency of the symptoms. We're going to talk a lot about differentials and what are some of the distinguishing characteristics and symptomology that would distinguish different of the anxiety disorders. And then, of course, some of the common shared treatment targets that are universal to all of these, OCD included,
Yeah.
And PTSD as well. Interesting how they used to be considered all under the anxiety disorder category in the previous edition of the DSM. But we'll look at some of those shared features and treatment targets. And then some real practical logistical in terms of CBT practice. What does the session structure actually look like? What does the treatment timeline look like? So a lot of really great content for you today.
Yeah, and I think one thing that's important to know as we hop into CBT is that CBT is a pretty standardized intervention. Of course, it should be individualized for each patient because the disorder they're presenting with, their current symptoms, they're going to look different, right? That's just part of sitting across from human beings. We're all different. We all understand things different. We see the world through a different worldview and lens. However, CBT as a whole should be pretty standardized. And what I mean by that is that if I go see Ryan, if I go see another CBT specialist, the session itself, the content itself should relate. We might use different analogies, we might have different language, right? But you should have a pretty good understanding when you see a good CBT clinician of like, oh, this is what a CBT session looks like. This is what we're talking about, and this is how we're doing appropriate behavioral interventions. And I think that's important because I think a lot of times as clinicians, we feel like, oh, there's like so much to learn and we have to know how to tailor it for this or for that, or if this person says this, do I say this? And I want us to really go back to the fundamentals and foundation of our work, right? If you understand the theoretical orientation that you're practicing within and you're a CBT clinician, you actually you don't need to worry about if a patient says this, what do I say for this? If they do it's how do I use CBT? How do I apply CBT, right? You should be able to generalize CBT. And so that's my goal for today is that you kind of understand what it looks like in practice, but that you're also really starting to say, what are my gaps in CBT knowledge and my understanding of CBT that might interfere with my ability to generalize it for a patient sitting across from me? Because you should be able to generalize it to patients that have similar symptomology and to a patient that you've never seen that type of symptomology, right? It should be translatable.
Exactly, exactly. So we'll see that as we go. Okay, so of course, the CBT model of anxiety, we're talking really about the CBT triangle: thoughts, feelings, and behaviors or actions. And remember that included in, thoughts, we're talking also about beliefs, we're talking about interpretations, attention biases, a few different things that are kind of falling under that cognitive category. All the things that all the things that are going on inside a person's mind, whether they're aware of them or not. We're looking at feelings. Remember, included in feelings, we're talking about emotions, things like sadness, things like disappointment, anger, but also sensations. Sensations are going to be a really big part of what we're talking about today because they play such an important role in anxiety disorder and OCD symptomology. And then behaviors. Healthy behaviors, unhealthy behaviors, adaptive, maladaptive, behaviors that are getting us stuck. And then, of course, when we're talking about behaviors, a lot of them are mental behaviors,
Yeah.
which is another thing that people miss sometimes, right? Thoughts are automatic, things that pop into our mind. We have no control over those, different than thinking, which is actually a mental process that we would categorize more as a behavior. So we're really looking at that when we do this. We're going to be teaching this to our patients. What are the connections between these, the types of thoughts we're having, how we're responding to those thoughts, the types of feelings we're having, how we interpret those feelings. Do they mean something? What do they mean? Do I need to do something about them? If so, what? These are things that patients are coming in. They're not aware of these beliefs. They're not aware of the way they're interpreting thoughts and feelings kind of non-consciously. Part of our role is pointing that out, showing them how those beliefs and interpretations and responses are either helping them or keeping them stuck, and then giving them alternative ways to respond instead.
Yeah, so two things I want to note about the CBT kind of triangle and our understanding of it is that it is very, very, very bidirectional, right? We should have done arrows that go both ways. But what we know is that your thoughts influence how you feel, which tends to influence how you act. And bidirectionally, right, how you act, your behaviors end up reinforcing your feelings and reinforcing certain thoughts. The beauty of that and the entire really like the entire kind of thought process and like the theory of CBT is that we can change our behaviors. We may not always have control over our thoughts or the way they make us feel, but we absolutely can control how we respond to them. Like that is something we do have control over. And if we start responding differently, it will also end up not reinforcing those feelings and thoughts, but instead changing them. And that's what's so amazing. I don't want you guys to feel like you're back in school today and we're doing a lecture, but this is important. Why? Because you should be explaining this to your patients. You should never be hopping into ERP for OCD, into exposure therapy for anxiety disorders, into CBT therapy for depression if a patient doesn't understand how it works and hasn't plug and played, right, their own symptoms into like see, oh, this is how I'm reinforcing those fears. This is how I'm reinforcing those maladaptive beliefs. We want them to see it and understand it way before we start to ask them to do behavior change.
Exactly. So this should really come very early on in the psychoeducation that you're providing to your patient, regardless of the specific diagnosis you're giving. And we really want patients, this helps them understand themselves, both themselves and the problem process that we're working on. But why am I having these thoughts? You're having these thoughts because you're giving them meaning through the behaviors and the responses you're taking in response to them, right? Why am I having these feelings? You're having these feelings because you're having certain thoughts that are triggering those feelings. And then you're responding in a way that is either reinforcing or intensifying those feelings, right? So when a person hears that and they can really make sense of it, like Liz is saying, that right there is already part of the recovery and the treatment process. Understanding and learning is really, those are the mechanisms of change. So we have to make sure that we start that process early on. Give lots of examples, lots of analogies. You want to have some of those ones in your back pocket. Ask your patients to give an example of that bidirectional process to something that's not even related to their anxiety. Like, oh, let's take a personal example or a relationship example and do this. And then they can really start to understand it and apply it to the difficult situations and symptoms in their life.
All right. So what we know is that this plays out the same way when we talk about anxiety, right? So you see this, the cycle of anxiety and what it looks like, it's very similar, right? Okay, you're triggered, you have an intrusive thought, and it causes you anxiety and distress, right? There's that threat appraisal followed by anxiety response, and then you start doing things to try to feel better. You either start avoiding those triggering situations so you don't have to be in them again, or you start doing some sort of safety behavior to feel better, to get rid of that anxiety that you're feeling and to start to decrease the intensity of that thought. Unfortunately, those behaviors, which by the way, we want to normalize those. We want to talk to our patients of like, of course you've been doing this. This makes sense. Who wouldn't? When you're feeling anxious and you're triggered, who wouldn't want to feel better? Who wouldn't want to do something to decrease the way they feel when they feel bad, right? When you don't feel good. But we also want them to see, but can you see how this is actually maintaining the cycle, right? These sort of avoidance behaviors or safety behaviors are actually telling your brain and body that there is something to be afraid of and that this is dangerous. And if we're trying to tell you and teach you that anxiety is not dangerous across the board all the time, when in terms of, your anxiety disorder, we have to make sure we're responding that same way and we're responding to our body, to our brain that this isn't dangerous and there it is.
Exactly. And the beauty about CBT, and because this cycle that you can see that's laid out, the anxiety maintenance, the anxiety cycle, the four different steps here to the process, you could take any of the anxiety disorders, OCD included, and plug it in, even PTSD, right? And that model will map it out for you and make sense of it. It's happening with all the different disorders, right? And with CBT, we can actually start at any of those phases. We could start with the threat appraisal part of it. We could start with the anxiety, with the avoidance and the safety behavior part of it. We could start with the anxious response part of it. We could start with the trigger itself or all of the above, right? And that's what, kind of what Liz was saying earlier about the CBT approach. If we understand the approach, we know what the problems are, we know how they're playing out, we know how to disrupt them and fix them. We're doing the same thing. Maybe Liz starts with her patient at threat appraisal. Maybe I start with the, avoidance behaviors. We're going to end up at the same place. Maybe the order is a little bit different. That doesn't actually matter as much because we know we're working on the same things. We know what the problems are. We're suggesting the same types of adaptive responses in place of that. The threat appraisal piece is really interesting. In some ways, maybe that's the most important, which is triggers are normal. Triggers happen to everyone, whether you have a disorder or not, right? Anxiety response is also normal and happens to people, whether you have a disorder or not. But the threat appraisal is what's different, and that's kind of what makes the disorder. And one way of looking at, well, is it GAD versus panic disorder versus health anxiety versus OCD is, well, what is the threat appraisal saying? Are you saying anxiety itself is the danger? In which case, maybe we're looking at an anxiety sensitivity underlying this. Are we saying the thought itself is the threat? Sounds more like OCD. Are we saying a panic attack, which might be a product of the anxious response, is the threat, is dangerous? We're looking at panic disorder. Is the idea that something is wrong with my health? I might be sick. I might be dying. The threat that your threat appraisal, and then we might be looking at illness anxiety disorder. So we're looking to see what is that cycle. You want to start to get a sense of that with your patient by asking them in your initial intake, what's the problem? What's going on? Walk me through. When's the last time you were upset about whatever the problem is? How did it start? We want to see what are the triggers, right? What are the things that are setting this process into motion? What is their threat appraisal? What are they really worried about? We'll talk more about core fears, which we have in the past, but what are they really afraid of happening? What do they think is dangerous? That's going to help us inform the diagnosis and the treatment that we're going to be doing.
And a little bit of a spoiler alert is that one thing we find is that the threat appraisal is anxiety itself, right? Is that people attach meaning to anxiety. And so they end up attaching meaning to their trigger through, like they end up, once they attach meaning, then it's like, oh yeah, you're probably gonna avoid or you're gonna do a safety behavior, right? But like the threat itself is just could be that feeling of anxiety, right? That distress. And so it's really important to note that we're trying to teach you to tolerate it more, but we're trying to also teach you to not attach meaning to those thoughts. Like, can you have the thoughts? Can it cause you anxiety? And can you still choose to not attach meaning to it, to not make anything of it?
Exactly. So that's exactly, if we look at that, right? So you could still have a trigger, you could still have an anxious response,
Yes.
but if we change that threat appraisal through cognitive and behavioral work, which we'll see, then there's no need to do avoidance or safety behaviors,
Right.
which would not reinforce the cycle, which would mean you no longer have an anxiety disorder. It's pretty amazing how that works.
It is, yeah. So as you'll see, one of the things we were just showing is that we will talk today about inhibitory learning and about what we kind of expect to happen and why and what that will look like. But those are both kind of important new research findings that we know that through CBT, those are byproducts of CBT. As CBT happens, inhibitory learning starts to happen as well, where people start to learn, I can do new things, I can have new experiences. And again, I always like to generalize this, but this has happened to you or to any of you throughout your entire life, right? And we want to talk to patients about that, whether it was when you learned to ride a bike, when you learned to drive a car, when you learned to walk for the first time as a toddler, right? We've all done things that felt uncomfortable and we've learned, oh, I can do it, right? You
Yeah.
learn something new and it also changes the way you feel about that. Oh, I'm not scared anymore to do it because now I've done it and I do it with confidence and now I don't even think about it, right? It doesn't even cause me any distress. It's just a natural behavior that I'm doing.
Yeah, yeah. A simple example, personally, I'm thinking about like test anxiety. I used to always get super anxious before a test. I was a good student, but it kind of would get worse, and I would start to think like, oh, I can't take the test if I'm this anxious, and I have to make. But through a process of inhibitory learning, basically what happened is I learned, hey, I can be anxious and I can still perform really well on the test. That lowered my anxiety. But you know what? I still might feel anxious if you give me a test, but it doesn't bother me anymore. It's just, okay, it's there, but I still know I can do the thing and I can do it well.
Yes.
Okay, so we're going to actually go through some of the main, the most common, most prevalent anxiety disorders that you're probably seeing in your practice, or may start seeing as you move into the space of anxiety and OCD treatment. Anxiety disorders are extremely prevalent, extremely common. I think I was reading something the other day about, in the 90s and early 2000s, depression was like the most common diagnosis, and it was showing up everywhere. And then sometime around like 2005 and six, the numbers started to show anxiety disorders were really starting to see a spike. And nobody knows exactly why. Lots of theories about that. Books have been written trying to explain that, but for whatever reason, that's stuck. And anxiety definitely seems to be something that almost everyone can relate to in some form or another, whether you meet clinical criteria for a diagnosis or you're just experiencing anxiety as a part of life. You can see some of the statistics here, but probably the most important one of these statistics is that CBT works really,
Yeah.
really well for anxiety disorders. We're so lucky that we have a treatment that is so effective for something that affects so many people and can be so debilitating.
That's right. And it should be, and we know as clinicians and as evidence-based clinicians, meaning we do stuff that's backed in research, that it is the first line gold standard intervention. So we should not be trying other interventions before we try CBT. We should be trying CBT first. Why? Look at the percentage in front of you, right? 60 to 80% of people get better with CBT alone when we're talking about anxiety and anxiety related disorders. And so that is where we should start to give them the best chance of successful outcomes.
And for what it's worth, Liz and I were doing a presentation the other day about something similar, and I can't remember the exact authors on the study, but they were looking at CBT for anxiety disorders, CBT alone, and then CBT plus medication. And they actually had the same outcomes, which were really positive, 70, 80% recovery. But even adding in the medication didn't change didn't improve the outcome at all for CBT, which is pretty remarkable. Okay, so we're going to go through a few of the main ones. Just talk a little bit. I'll do a few, then I'll let you take over. But generalized anxiety disorder, this is extremely common. Really, the main pathological process that you're looking for, that is kind of the hallmark of GAD, is a worry problem. Patients, a lot of what ifs, what if this, what if that. And what kind of really separates GAD from some of the other ones is that the worries, they're not usually about one or two particular things like their health or a very specific phobia, right? One specific fear. They're about lots and lots of different things, and they tend to kind of change as the day changes, as the week changes, as the things in life change, work situations, health situations, relationship situations, all kinds of things. So these patients are constantly experiencing worry and they get very caught up in the worry process. The problem is that the worry process itself, which is a mental behavior, creates, as we said, behaviors affect how we feel and they affect thoughts. That behavior that the patient is engaging in, which they feel is just automatic and happening to them, creates the feeling of anxiety and makes them feel super anxious. It also then creates the urge to avoid situations that are going to make them worry or over prepare for situations, do safety behaviors around anything that might make them worry out loud, and it can become really bad. One big myth that I'd like to dispel right here is that GAD, there's this kind of perception. I hear a lot of clinicians say this or patients say this, that like, oh, well, GAD is just kind of like, it can't be that severe, right? It can't be that bad. And I think because maybe it's such a common diagnosis that people have that, I'm not really sure where this came from, but GAD can be really bad.
Very severe.
It
Yeah.
can be very severe.
Part of it is just because everybody lives with anxiety. And I think people think like, oh, generalized anxiety disorder means that's just the anxiety that like most people generally have, where it's like, no, we're still talking about a diagnosis. So I think one of the important things, as Ryan said, is GAD is anxiety that tends to really jump around as well. So you see where people with GAD worry about things that most of us worry about, losing our job, driving, right? Those sort of things, but it starts to impact their life. And we can see patients with GAD no longer working, totally homebound, not driving, not functioning because of
Yep.
their anxiety levels.
Yep. And it can, as you say, it can get really bad. Some other kind of things we notice with GAD that are important is oftentimes patients with GAD, when they have a worry about something, their problem-solving skills tend to break down because sometimes the things they're worried about are real problems. It's not always kind of these hypotheticals. And they might be otherwise very smart, capable individuals, but when the anxiety shows up and when the worry process shows up, their natural ability to problem solve kind of breaks down. Or they had a pre-existing kind of problem skills deficit that is now made worse or exaggerated by the GAD. They oftentimes have kind of a negative, what we call a negative problem orientation, where because of the worries, they'll kind of view any situation, maybe it's a neutral situation or even a positive one, but their mind is kind of telling them something bad's going to happen, this isn't going to work out. And so that can also kind of become a self-fulfilling prophecy. Let's talk about panic disorder. This one is very, very important to note, right? Panic disorder does not mean your patient comes in saying, I have panic attacks.
Or I've had a panic attack.
Exactly.
Because most people, by the way, have had a panic attack in their life. Most of you watching have had one for different
Exactly.
reasons.
Or will have one. Exactly.
Yeah.
So having a panic attack does not mean you have panic disorder. Even having frequent panic attacks does not mean you have panic disorder. Panic disorder is defined by one thing, which is a fear of having panic attacks,
Yes.
right? And so that makes all the difference because there are people I know that have panic attacks, but they don't like them. Nobody likes a panic attack, but they're not all that bothered by them.
Maybe they're not afraid of them. They don't
Not
really
afraid
care.
of
They're
them.
like, yeah, it's uncomfortable.
Part of my
Yeah.
job, or like,
Yeah, I get it. Yeah.
And so that's not panic disorder. That's just a person that has panic attacks, right? Panic disorder, you'll know it because the person is coming in saying, I can't have a panic attack. I will do anything to make sure I don't have a panic attack. I'm no longer leaving the house. I'm no longer driving. I'm no longer going to work. I'm no longer approaching social situations or whatnot because the fear is having a panic attack. This is very important because when we talk about differentials, gets back to like, what is the core fear? Somebody comes in and they say, I avoid social situations. You might think, oh, social anxiety disorder. Not if what they're afraid of is, I avoid social situations because I might have a panic attack there, right? You're talking about panic disorder that looks like social anxiety. Even sometimes OCD, we'll see people where they're doing rituals and it looks very much like it's OCD, but then you ask them, well, what are you really afraid of? Well, I'm afraid of having a panic attack. If I don't do the ritual right, or if I, don't avoid this situation. Well, that's actually better defined as panic disorder.
Yeah. And again, this is why it's so important when you're treating anxiety. You have to know, like, what is the actual fear? What are people afraid of? What are they doing safety behaviors for? Because sometimes we were actually talking about this today, we were case conceptualizing at lunch, is sometimes patients are like, this is my OCD, I need to do ERP for it. And we're like, actually, that's a trauma response, or that's panic disorder. And we don't need to do ERP. We need to do a specific CBT intervention that works for panic or that works for PTSD. And so we need to be really thoughtful about that.
Exactly. And what the person's actually afraid of is really informing the targets for your treatment, what you're actually going to be focusing on with them. asking them to move towards or to challenge some thoughts and beliefs about that. So if we're missing the fear, if we're missing what's actually driving the disordered behavior and the disordered thinking, we're really going to be missing the mark.
That's right. Yeah, and one thing I just want to note is, today's presentation, we're talking about CBT because we want individuals, you guys, to understand the intervention, and I always like to call it like an umbrella, right? But like the umbrella of the theoretical intervention that works for all of these disorders. But it's important to note that within each disorder, there's a specific type of CBT that works best. For OCD, it's ERP. For trauma, it's prolonged exposure or CPT, or there's some evidence now for EMDR. For other disorders, maybe for phobias, it's going to be exposure therapy. And so, sometimes these broad CBT interventions do work, but there is like specific protocol and targeted CBT interventions for each disorder. And so you might say, well, why does it matter if it's GAD versus social phobia? Well, it does matter because the specific CBT intervention you're doing is going to be different and it's going to be appropriately tailored and target the specific symptoms that they have.
That's a great point. And I would say if you're newer to CBT, you're newer to treating the disorders with CBT, if you're able to diagnose, GAD, panic disorder, there are manuals that actually manualize CBT for these disorders in specific ways. And I would recommend ordering some of those clinician manuals so that you can see exactly how is CBT operationalized specifically for this particular diagnosis.
That's right. So we're not going to go through all of them, but overall, I think just it's important to know each disorder and there's different fears. And so you really want to get to and understand what exactly is the fear, why exactly are they doing these avoidance behaviors. Our favorite question or analogy is WTF, but like, what's the function, right? What is the function of the behaviors? Is it because I don't want to have a panic attack and that's what I'm afraid of, and everything I'm doing is to prevent having a panic attack, so I'm not going in public anymore and I'm not, right? Okay, that's more panic disorder. Is it, well, I don't want to do that because I don't want to have to make a decision because I'm struggling to make a decision and they're anxious and worrying and it fits better as like GAD, is it a specific phobia? You want to know that. All right, so as you know, we can't talk about evidence-based treatment without talking about and sharing the fact that there are great, specific, validated, effective measurement tools. So for all disorders, we really want you guys measuring to do two things. We want you to use a measurement tool to diagnose and to appropriately understand severity levels. But more importantly, we want you to use measurement tools throughout treatment to make sure your patients are getting better. We should not, as clinicians, be using like this anecdotal evidence of, oh, they seem better or they seem happier in session. We want to be able to measure that. We want to be able to show that, hey, you came in with severe anxiety and you left with mild anxiety. You came in with severe OCD and you left with mild OCD. We want to show that and document that and be able to really appropriately understand it.
Exactly. Yeah. We're really, measurement-based treatment. We're able to track progress and that should be used in combination, as Liz is saying, right, with our observations of the patient, their self-report, and these very concrete measurement tools that we can track over time. And you can decide based on the tool and the patient and the frequency of the sessions, how often you're seeing them.
Sure.
Does it make sense to administer this once weekly, every 2 weeks, every 3 weeks, depending? There's not necessarily a right or wrong answer, but you can seek consultation on this. But it absolutely needs to be a part of how you're evaluating progress. That is a core principle of CBT treatment that separates it from some of the more kind of diffuse, unstructured talk therapy, where it is very hard to gauge progress.
Yeah, CBT is goal oriented, it's short term. Typically I say at minimum, do one at the beginning at an intake, do one midway through, and do one at termination. But if you want to do it more frequently, go for it. So these are just a list of some of the different validated and measures that are often used. I know for us, we use GAD-7 here all the time. And we use, certain ones for depression and of course OCD, but there's lots of different measurements that you can look into. I always want to find one that I'm using that is the most validated, that's available in the public domain, so I can, use it hopefully through my EMR, but also one that is short. I don't want a 30-minute measure I'm doing with a patient in session. Remember, just kind of a caveat for those who don't use measurements as much, but you're going to start. There's usually both what is called a self-report measurement or a clinician administered. Make sure you're using the right one. So a lot of us will have our patients do the self-report measure in between session or before they come in for the next session, so it doesn't take up session time. If you're doing it in session, make sure you're doing the clinician administered measurement.
Yeah, these are just some more formal, structured clinical interviews, which you can use. These, again, if you've had some training in this, it can be more helpful. Oftentimes, this isn't necessarily needed. I think sometimes if you have a more diagnostically challenging patient who's maybe not good with self-report, or there's some conflicting information they're giving you, or your behavioral observations are very much at odds with what the patient's reporting to you or what the family and collateral are reporting to you, you can kind of look to some of these more structured clinical interviews. And then, of course, we've got our more kind of CBT bread and butter. These are things we should be doing kind of all the time. We are really, as patients are talking, we're trying to listen for some really important key things, which are those core beliefs. In CBT, these are beliefs about self, about others, and the world around us. And really, if we're looking at a particular diagnosis like GAD or social anxiety, we're looking for beliefs about the disorder or beliefs related to the disorder. So, like, people don't like me, maybe is a common belief in social anxiety. That belief is fueling behavioral choices like avoidance. Well, if I really believe that people don't like me, then I'm much more likely to avoid social situations, even if I'm not feeling all that anxious, right? So anxiety plays a role, but also my beliefs and my interpretations. If I'm interpreting that every time I have a social interaction, it's going poorly when maybe it's actually not, that is going to be more evidence my mind uses to convince me to avoid or to give up. Right. So we're listening all the time for things patients are saying that are really important, like, oh, there's a belief, there's an interpretation. We can challenge it directly through kind of cognitive interventions, examining the evidence for and against, or the usefulness of it. Hey, so if you really believe that, is that helping you move towards the life you want, or is that making it harder? What do you think some of the effects might be? Getting the patient to kind of think about it, appraise the cognition. And then also we can test it out. Our favorite is behavioral experiments. Your mind is telling you that you have negative outcomes when you go into social situations. Well, let's test that out, because sometimes cognitive, talking back and forth or challenging their thoughts, sometimes it works great. Sometimes you go nowhere.
Yeah,
Yeah,
and even if it works, it usually only gets you so far. You
exactly.
still have to actually practice
You
it.
still have to practice. You
I
still
can
have
think
to do
about
the
going to the
behavior.
gym all the time, but I'm not going to see the results till I go.
Exactly. So we love to challenge beliefs directly through behavioral experiments. Behavioral analysis, Liz mentioned our favorite WTF, what's the function? You should kind of be doing this, especially with the patient's more entrenched problematic behaviors, kind of observing how they are in session, or when they're telling you about a challenging situation outside of session related to the disorder. Kind of asking more questions. Well, what preceded that event, right? We're looking for the antecedent event, right? So what was the trigger? What was the thought that happened or the situation that you found yourself in where the problem behavior started? What did you do? What actually was the behavioral process of the situation, the challenge that you faced? And then what did you do after that? And what did you think about it afterwards? How are you kind of processing it mentally? We're looking at that behavioral analysis. What was the function of that behavior? When you avoided, did you feel better? When you told yourself this thing, you know what, I don't need friends anyway. I don't really care that much about social situations. That was an effort to make yourself feel better about the fact that, like, you're not going to social situations. So we're constantly thinking about patients' behavior, what function it serves, what effect does it have. Oftentimes patients are aware, a lot of times they're not.
And sometimes they're like, well, I went to that event you told me to, and it still didn't go well. And I'm like, okay, well, let's talk about what happened. Oh, well, I sat in the back row. I didn't make eye contact. I didn't talk to anyone, and I left before it was over. Well, yeah, I mean, you probably didn't make more friends because behaviorally you actually were acting as though you didn't even want to try, like you didn't want to give it a chance. And this is important. So sometimes even when those experiments don't go as planned, we get and they get really good information about, can we try to do something different, right? Is there a way we can change our behavior to have a different outcome? A question that came in that I do want to address now versus later, because I think it's important, is, what is the difference in this kind of like behavioral analysis and understanding the fears versus like getting to the root or core of it? And like, how do you separate CBT from going into, because I think a lot of folks, especially if they're not CBT based, they hear this like core fear, or they hear behavioral analysis and they're like, oh, we're supposed to like figure out what it's rooted in and where it comes from.
Yeah.
Like, what's the difference?
Great question. Yeah. So when we use the term core fear, we're really talking about tracing the fear down to its most basic thing that you're afraid of. So, for example, if I tell you, well, I'm afraid of going into social situations, if we're not asking about core fears, if we're not tracing that fear down, you just assume if you leave it there at the surface level, well, the person's afraid of social situations. Sounds like they have social phobia. But if I say, well, what's so bad about social situations? Why are you afraid of social situations? Why do you avoid? Well, because the last couple times I've been in a crowd, I've had a panic attack. Oh, okay, so you're afraid of having a panic attack, but we're still maybe not to the core fear yet, right? Well, what's so bad about having a panic attack? Why are you afraid of having a panic attack? Well, the last time I had a panic attack, I kind of felt almost out of body, like I was dying, like I wasn't real. It made me think I'm going crazy. I'm really afraid of going crazy, right? Maybe we're there yet, but we'd still ask, well, what would be so bad about going crazy? Well, then I'd end up in a hospital. My life would be over. I won't have control, right? It could be a lot of different things, but we need to actually trace that down and figure out what is the core. So that is core fear work. That is getting very specific with the patient, you and the patient on the same page about what thought, what feeling, what sensation, what idea you're actually truly afraid of that's driving the disordered behavior versus this kind of more psychoanalytic or psychodynamic perspective where the idea is that we're acting on things that have happened to us in the past, urges or desires or situations that happened that we're not aware of.
Yeah. I
And
think the difference is like, okay, like you have a fear of going crazy and being out of control versus like, let's try to explore where that
where that
comes
came
from. And
yeah,
like, does that come from, did you know someone or did you experience that? Or did that come from childhood and starting to really unpack
yeah,
this and go down a path that again, from a CBT lens, we actually don't, unless there is an active trauma, right? There's like something else. Of course, if there's active trauma, we need to be doing trauma work and address it as PTSD. But otherwise, that actually keeps patients more stuck
exactly.
versus because they think they're going to like talk their way or figure their
Talk
way
their
out
way
of
out of
it,
it.
and that
Exactly.
doesn't happen.
That's really the caveat that, a psychoanalytic perspective would say uncovering the root or the origin of that fear is going to unlock it and then it'll go away. But, research and evidence and clinical experience shows that just doesn't happen. The only way to get rid of a fear is to change the way you're responding to it and approach it. And
Especially because half the times these fears aren't rooted in anything. They're
exactly.
really just like they just happened and they're
Exactly.
more rooted in the fear of anxiety and like distress,
Yeah.
but they're not, it's not necessarily related to some childhood incident or something that
And
happened.
it's also impossible to prove. The
Yeah.
patient, we don't know. Maybe it is, maybe it's not. It doesn't really, knowing that, maybe it could be helpful to have some context or the patient can help validate themselves. Yeah, this is hard for me because, when I was a kid, I was bullied. That's great. That's important information, but it doesn't change the fact that
Yeah.
we still need to change your behavior. We need to change the way you're thinking about this.
We need to help you move through it, right?
We
In
help you
life,
move
we
through it.
kind of think about this like you can be scared to take an exam, but we still have to figure out how to get you to take the exam. And we have to, and when we do that, it will help you move through those fears that are at the root. And so, yeah, so there's a big difference in like what is the core fear and what are we targeting through anxiety treatment and through CBT versus is there something that we need to uncover and like we need to unfold and we need to spend time unpacking it? Because again, remember, CBT is often short term, 12, 16, 20 sessions. It's very goal driven, right? What are the things that you're currently not doing, the things you're avoiding, the safety behaviors you want to get rid of? And we are going to do everything we can to target those, get rid of those, and address those through active goal oriented treatment and through treatment that you're going to be getting homework each session. Like that's an important piece. You're doing the work, the behavior work in between sessions. We can't do it all in 45 minutes when we see you.
And even trauma, the last thing I'll say about this, but this is where I kind of like the previous version of the DSM putting PTSD and OCD all together with anxiety disorders because it really is the same cycle that plays out. Even if we can really validate that there's a good reason why the person is afraid of traumatic memories or traumatic thoughts or certain places that remind them of triggers, right? We can really validate that and understand because some real criterion one incident did happen. We still, at a certain point, have to ask them to be willing to sit with the memories, to move through them, to experience them in a different way, and then go do things where they are going to be triggered. Like it's the same process
That's
of
how they get freedom.
it's how they get
It's
freedom.
actually how they get unlocked from it is being able, in PTSD, we call it like everybody has this normal bell curve. And most people, when they experience a trauma, they recover naturally and they kind of have this natural response. But of course, right after trauma, anybody has certain heightened arousals, but we expect that to go down. But you receive a PTSD diagnosis when you literally what we call get stuck in your recovery, right? You're not naturally recovering, you get stuck somewhere. And so our job is to figure out, it's usually avoidance or safety behaviors, right? But there's what we call stuck points from a trauma lens that we need to figure out What are your stuck points? What are the things that are keeping you stuck and why? Let's remove those and change those. And then guess what happens? People actually naturally recover. They get back on that bell curve and they recover. And that's what's so beautiful about CBT and anxiety treatment is it works. It really does have this incredible mechanism of change that's fast and efficient. And it's often like people will say, we saw this yesterday with a patient where they're so scared of something, but everything they're doing is making it worse, that when we're finally like, no, we're going to approach this, you're going to say these fears, you're going to say the things, it's almost like there's relief.
So much
Like it's
relief.
actually
Yeah.
easier
Much relief.
to approach this because I don't really have a choice anyways, but I'm approaching it with hesitation or white knuckling or with safety behaviors that's making it worse, that's
And
reinforcing it.
that's where the patient's agency and power is in being willing to face their fears. And it's a beautiful thing when you witness it happen. And that's what we want for people with CBT.
And this leads perfectly into our next section, which is really understanding differential diagnosis and when we need to kind of consider this and take it into play when we're doing any sort of CBT, but any intervention at all. Yeah, so we want to be able to understand the difference between GAD versus health anxiety, social anxiety versus panic, GAD versus OCD. And again, you might say why, and I will be the first to tell you, I think sometimes there's, we can kind of say, all right, it's clear this person has OCD, and then sometimes you're like, that sounds a little bit like GAD, and sometimes it may not be as big of a deal to like dive into it if they're really doing the work and understanding CBT because they can apply the concepts. But sometimes what we find here, and I'd love for you to talk about this, is we've seen a lot of cases where they've been treated as OCD being their primary and only diagnosis. And when they come, we're actually like, this sounds like only GAD.
Yep.
And why, I guess my question as a clinician is like, why is that important if we're using CBT regardless?
A great question. Even though we're using some similar interventions, the pathological processes, the mental processes we're going after, and some of the behavioral ones too, are looking a little bit different. And so we need sometimes to really have a specific modification on deck. GAD and OCD is a great one to start with to illustrate that, right? So, for OCD, the primary mechanism is exposure of recovery of treatment is exposure response prevention. Exposure is useful in GAD treatment. However, if you're using that as the primary treatment, you're basically just going to be chasing fears all day long. Yeah. Okay, you're worried about this, go and approach it. Let's do an exposure for it. They might get some relief from, oh yeah, okay, that wasn't so bad. Well, guess what happens in 5 minutes? They have a new worry.
And GAD has even more frequent worries and it jumps and it shifts than OCD,
Yeah. So if you're not addressing, well, we need to help them understand that this mental process of thinking of worry is a problem. And guess what? Worry is actually egosyntonic because oftentimes patients have kind of positive beliefs about worry, what we call in CBT positive beliefs about worry that, yeah, worry, I don't like it. It's not fun, but it helps me.
It's functional.
It's functional, yeah.
It allowed me to understand something better.
Exactly.
That's why I did well on my test, is because I was worried about it and then I studied more.
Exactly, right. So they're much less willing to give the worry up unless we kind of address those beliefs about worry, right? Whereas with OCD, patients, no part of them wants to be ritualizing. They're only doing because they feel like they have to. So they're more willing to give that up if they can face the fear and see, I can do this. It's okay. Those are just thoughts. Those are just feelings. I'm stronger than that, right? So you can see it's the same application, but we are looking at these kind of differences. They're important. The psychoeducation is going to be more tailored to GAD, to OCD, based on what is actually those pathological processes that the maintaining factors we're going after.
Yeah. And the same goes for any of these disorders. When you understand the difference of like, is this GAD versus health anxiety? Like you are going to do things a little bit different, right? And they do look different, right? This kind of worrying about multiple life domains that shifts versus like, I'm really worried about my body symptoms and, medical, something catastrophic happening or some diagnosis that I'm worried that I have, that sort of thing. And again, we talked earlier about panic versus, social anxiety. Is someone afraid to go in public because they have social anxiety and they're afraid that they're going to get embarrassed or that people are going to perceive them a certain way? Or are they afraid to go in public because they're afraid they're going to have a panic attack? We want to know that. Why? Think about treatment. We're still using CBT, but for panic disorders, we're actually going to evoke panic. We are going to do interoceptives. We're going to spin you in a chair. We're going to have you approaching and allowing the possibility of having a panic attack and teach you how to not care and how to learn to tolerate that. I don't need to do that if it's social
Yeah.
anxiety. I
Mhm.
need you going in public. Like it's much more important for me to have you going in public. And, so again, we want to know what's the specific fear and how can we use an intervention, a behavioral intervention to target that specific fear so that you can what? Have new learning happen, right? We want our targeted interventions to allow inhibitory learning to happen, meaning to allow your thoughts and your anxiety or the way you feel to change. Oh, this actually I learned something new, or I learned that wasn't as bad, or I learned I can tolerate that, or I actually don't have to be afraid of panic. The learning can't happen if we don't approach our fears through a specific intervention. And so all this is important. You have to know it all.
Exactly.
You have to tailor treatment appropriately.
Exactly. The we're going after the maintaining factors, and for any of these discrete individual disorders, there are some common maintaining factors, right? Now, if you get 10 people with GAD, they're sharing most of the same maintaining factors. Individuals, some different, there will be some difference, but most of them, the main primary ones are the same. That's why, to go back to kind of what you were saying earlier, consulting a manual, a clinician CBT manual for the specific disorder is going to do a lot of the work for you because they're going to tell you, hey, if it's GAD, here are the main
Yes.
maintaining factors in generalized anxiety disorder. If you're working with health anxiety, here are the main maintaining factors. You don't have to do all that work yourself. Once you get good at this, you'll see them,
Yeah.
it'll be obvious to you, and the ones that are unique to the person in front of you. But the primary core pathological maintaining factors, they're going to be so much overlap in each of these disorders. Um, yeah.
And we could share this chart, a lot of these, but just so that you'll see that, yeah, there's lots of different ways to separate it. So again, what we've talked about so far is treatment, what we're tailoring, how we're approaching it, and what we're thinking about. And now we're going to hop into what are the primary treatment targets? What are the shared mechanisms of change that we're expecting and looking for? The first is avoidance reduction, right? So we need to be asking our patients who are coming to us, who are presenting with an anxiety disorder, any of them, what are you currently avoiding? If you didn't have this anxiety disorder, what would you be doing? How would your life look different? What do you want to get back to? What's important to you, right? And we want to know that because that's going to help us understand what to start with. They're going to be more motivated to do things that they wish they could do or that they used to be doing. But also, you can't ignore that. Avoidance plays the same role as safety behaviors and other reinforcement. Number two, we want, like Ryan was talking about earlier, we want to really think about how we modify this threat appraisal. How can we start to challenge their overestimation of the threat and of their fears, and what does that look like? Number three is we want to start to teach people that we want you to be able to tolerate uncertainty broadly. I think a lot of people struggle with this a little bit because they're like, well, no one likes uncertainty. Well, of course not, right? Think about COVID. It shut the whole world down. Even, prolonged time after, a lot of us were still really struggling with the uncertainty around it and the anxiety around it. It's not fun. Nobody likes to be worried, be stressed, have uncertainty. Yet what we also know is that you can't avoid it. It happens all the time. And we're trying to teach you to tolerate uncertainty like most people do, which is most people tolerate uncertainty unknowingly. Every time you get in a car, you are tolerating a lot of uncertainty. But you probably aren't sitting there thinking about it before you get in your car and drive and put your car in drive and take your foot off the brake, right? You're just driving. You're not thinking about all the things that could go wrong. We want to eliminate and reduce safety behaviors, as we've talked about. All those do is reinforce that threat appraisal, that anxiety is dangerous, that you can't tolerate it, and they make it bigger. Of course, we also want to think, and I love this one, but like thinking about cognitive and emotional avoidance. I think a lot of times we focus so much on behavioral, like what are you actually avoiding? And we don't talk about what's going on internally, right? What are the ways that when you get triggered or anxious, you're trying to suppress that mentally, or you're trying to not have to think about something that's scary? Is it that I turn my music on really loud when I'm try to sing along and distract myself when I'm feeling triggered? Like, what are the things I do that are still reinforcing anxiety is dangerous? I can't tolerate it, that sort of thing. And then, of course, psychoeducation and anxiety normalization. I should probably fix this slide where that's number one, but we talked about it earlier. Like, you should spend quite a bit of time on psychoed, on normalizing behaviors, on helping patients see why, like, yeah, it makes sense you've been doing this. No one likes to feel distressed. And the cycle is actually creating the distress. It is the problem. Like the fact that we're kind of, responding to anxiety is why we still have anxiety.
Exactly. And it's amazing these six main common factors, maintaining factors in these disorders. And these are the targets we're going after in treatment through both cognitive and behavioral interventions. But if you put these six up here and you gave me any of those anxiety disorders, I could write out exactly this is what people with GAD avoid. These are the types of threat appraisals that with GAD. These are the types of uncertainty they're not willing to tolerate. The safety behaviors that you see, the emotional and experiential avoidance, right? And we know that because we've seen that over and over again, and you'll get really good. But any of those disorders are going to have these same treatment targets. They're just looking a little bit different.
Yeah, so, exposure therapy is one of the most widely used and known CBT interventions that's used for multiple different disorders and anxiety disorders, from specific phobias to GAD, and even we use some exposure through interceptives and different things for panic disorder. But what we know when we think about exposure therapy is not, let's just see how triggered we can make someone, right? It needs to make sense for their pathology, right? Whatever they're avoiding, whatever they're struggling with, exposure should be tailored to that. These should be values based. They should make sense. The person should want to get back to these things they're avoiding, whether it's driving a car or going to work or sending that email. It doesn't matter. We need to help them do the exposures related to that. But the old school model of exposure therapy focused a lot on habituation, on the idea and concept of you do an exposure and you wait until your anxiety reduces. Inhibitory learning is very different, right? It has taught us that, hey, when we actually engage in different behaviors, we can start to feel and think differently about things. And it's focused much less on anxiety level and much more on what were you able to do despite the fact that you felt bad? What did you learn? What ended up happening that next day or that next time you went to go do that event, or go to that event again or do that thing again? And so we want to focus less on anxiety and more on what we learned. Why? Because if we're focusing on anxiety, it's kind of hard for us to say, hey, we're treating anxiety if it's not dangerous, but we're still focused on it and waiting for it to reduce. We actually don't really, I always tell people when they're like, well, what do I do about anxiety? I'm like, you just quit caring, right? It's like panic attacks. It's not a disorder if someone has panic attacks, but they don't care about them, right? Because again, it's not impacting their life. They're like, yeah, I have some panic attacks, but I don't care. They don't bother me. They're just annoying. Same with anxiety. Anxiety, no one really is going to want anxiety or want to welcome it, but if you're not afraid of it and you're not distressed by it, it won't have any control or power in your life anymore.
Yeah, and we won't go through all these different types of exposure, but these are all very important. I think in the future we could do a whole webinar on just the different types of. There's so much misunderstanding about imaginal exposures and how to do that effectively for OCD or other types of anxiety disorders. But these are all ones that we frequently use, both in vivo, imaginal, interoceptive, situational, and I don't know, we
Yeah.
haven't done VR, but maybe. Oh, that's right.
Some of my
That's right.
different work, especially for
Yeah.
PTSD, I've done a lot of VR exposures. And so we can talk about that. I do think we'll do an
Yeah.
entire webinar on the delivery of exposures, what they look like,
Different
and what a
types.
good exposure is versus a bad one. We've done a lot on good versus bad therapy. We should also do that on good versus
Yeah.
bad exposures in CBT.
And then the kind of final section is just the real logistics of session structure and the treatment timeline. I think you guys hopefully are familiar with this, but this is just an example. Again, this is not rigid. It's different for different people, but you have some, in general, different phases of treatment. In the beginning, you're really looking at assessment, diagnosis, case conceptualization, treatment planning. Then you're really going to be moving into providing a lot of psychoeducation. You want to make sure your patient actually understands what the problem is or the problems are, and that they understand the rationale for why you're asking them to do what you're recommending as part of treatment. And then we move into that active part of treatment, which oftentimes does include, if not exposure, heavy behavioral elements. We really like to start with behavior change because that oftentimes gets a lot of the cognitive stuff moving. You can, of course, start with cognitive interventions as well. CBT is flexible that way, but you really want it, whether it's cognitive or behavioral or both, it needs to be active, it needs to be
right.
action driven and measurable.
Yeah, I want to be clear, just because we're talking about doing cognitive work, that doesn't mean we're talking about talk therapy. You're not just talking about it, you're doing a thought challenge worksheet, you're doing active things to help challenge cognitions if you're in that phase. But once we get to the behavioral part, right, the B in CBT, we really need to be doing active behavioral interventions, and that should be happening in session. I want to be really clear about that. I hear a lot of people talking about ERP and CBT, and then their patients are stuck and they want a case conceptualize, and then we break it down, and I'm like, well, what exposures have you done with them? And they're like, well, I assigned it to them. And I'm like, okay, no, like ERP, CBT, it doesn't matter, but like whatever
Yeah,
intervention we're
role
doing from a
playing.
CBT lens, you are doing it
Yeah.
together. You're empowering them, you're helping them see. And also, that's when you learn a lot as a clinician. You learn, okay, they're doing this, but here's all their safety behaviors they aren't even aware of in there, right? And so you're helping them identify that in real time and doing it together. But we're doing active exposures, and then we're moving into really helping. We can call it consolidation, but I like to call it generalization. But like, do I feel like you have generalized the treatment? Like, I always will play a game of like, okay, so if this symptom shows up, what are you going to do? If this trigger happens, what do you do? But I want to be able to like throw a GAD trigger at you, a social anxiety trigger at you, panic disorder, it doesn't matter. And I want you to be able to say, oh, well, this is how I would approach it. And that's the big thing I'm looking for is, do patients have a good understanding that the way to address any anxiety disorder is through actively approaching, welcoming, and actually eliciting
Mhm.
the anxiety and thoughts around that fear versus anything that's like avoiding it, suppressing it, or just trying to not have it.
Yep, absolutely.
And I think we'll do, I'm sure, many webinars on ACT and, different things. But I think one thing I just want to caution you guys on, those of you that are like, oh, well, I use more ACT than CBT, is make sure we're not using ACT as a way to avoid approaching exposures. Part of the behavior change is that patients have to approach their fears and triggers, of course, in ways that make sense and in ways that, are in line with values, but we can't just kind of, oh, I'm going to try to not think about that. I'm going to use mindfulness instead. You need to be actively approaching the fear. And eventually, sure, mindfulness and ACT concepts and all that can come into play, but we don't want to use that in lieu of
Yeah.
exposure.
You want to mindfully approach the thing
Yes.
you're avoiding.
Yeah. I love that.
And then yeah, the session structure, which again is flexible, but in general, and
This is how it should look, really.
this is how it should look. And I avoided the setting an agenda for a long time, and now I always set
Oh,
an
yeah.
agenda absolutely 100%. You need to be able to manage the time and also the patient's expectations to get things done. Your patients will thank you for this, even though it sounds like it might seem to you subjectively like, oh, this is, I'm being very controlling or I'm kind of taking the direction away from, but patients come in looking to you to lead and guide the session. You are the expert. You know what the problem is. You're helping them understand. You're coaching them through it. Take control, take guidance, and lead the patient to where they need to go. You do that by setting the agenda. Part of doing that is saying what's important to you to talk about today,
Yeah.
but you're also kind of making a judgment call on what do I really think we need to get to here to help them, because avoidance shows up in what they're wanting to talk about oftentimes.
Exactly. Yeah. And I think what's so important to note is that the reason we have this structure in place is because it's what works, but it also tells you a lot when it's not being adhered to. So, we come in, we check in, we agenda set for the day, we go through homework. Why? Because I want to know what you struggled with and I want to know what went well. The things you did really well with in between session, we don't need to spend time in
Yeah.
session doing that. We need to focus on the things you avoided or that you struggled to do independently. Then what do? We start doing the intervention. We start doing active behavioral interventions. That's why this is the bulk of treatment, right? The 30-minute mark, 15 to 40, but like it's the main part. We're going to do active exposures together. We're going to go spin in a chair. We're going to go touch that thing you're afraid of. We're going to cross contaminate, right? Whatever it is. And then we want to do some like psychoeducation. This is where that inhibitory learning model comes in. What'd you learn? What are you telling yourself? What beliefs are you still holding on to versus how have you moved through it? And we set the next week's homework assignment and we close. Why is this so important? Well, it's important because if you find that every week your patient comes in and they have a new crisis of the week or something going on and you're not getting to any of the homework review and active ERP, that's a problem. You're not going to have progress. Your patient is not going to see the outcomes that they originally set as their treatment goals when they first started treatment with you. And we want to keep them on track. And so, of course, things happen, right? Deaths happen, breakups happen, big things happen that sometimes that's what it capitalizes a session. No one's saying that you have to ignore that or not talk about it. But if we find that that's happening week after week and we're never able to get to the behavioral intervention, we're not going to see the outcomes. And our patients are then going to say, oh, CBT doesn't work for me. And we're like, not
We
really. We
didn't really
actually
do
just didn't do
CBT.
CBT. Yeah. So be thoughtful and recognize if they're avoiding certain things or certain exposures or certain homework, that should tell you something and allow you to tailor CBT to be more effective for them. So yeah, we know CBT works. I know we're running out of time, so we're not going to get to questions, but the most important question that I always want to get to is, and topic that I always want to talk about is, why do CBT? Because it works. There's incredible response rates to all anxiety disorders for CBT, and this should be very hopeful. It's one of the most effective mental health intervention that exists, and it works. Your patients get better, they get better quick, and they're empowered. It's not just that they went and did this hard work, like they're empowered. It makes them feel good. It makes them feel capable. They have ownership now over their anxiety, over their thoughts, over their illness.
We'll do more on comorbidity. I think this is deserves its own probably a series of webinars on comorbidity, but just a few things to consider.
A lot on comorbidities that might make you change your intervention and how they would,
Exactly.
But they're there. You need to think about them always. The key takeaways are that CBT is active, and you should be using measures to measure outcomes, and that you should be sticking to a model, right? I'm not saying you have to stick to a specified protocol and never stray from it, but it's not a bad idea if you're not a CBT clinician, you haven't been appropriately trained to do that. But what we do know is that there is a way in which CBT unfolds from assessment to intervention to termination that is pretty clear and it's pretty tailored and it's done for a reason. Exposures should be gradual because we need them to be done with full response prevention or where patients are not doing any avoidance or safety behaviors. We need to understand what's going on and we need to really meet patients where they are, but also push them. CBT is an active intervention that's hard. It's triggering, it's anxiety provoking, but it works.
It works, yeah. So I hope you guys have some takeaways here and you understand the way the model works, the way to apply it to a lot of different presentations to recognize kind of those common core processes and maintaining factors, and also the nuances that are specific to each unique diagnosis. So continue to watch these webinars. We're going to go deeper and deeper into lots of different topics. And I'm really excited to see where this goes.
Yeah, and like I said, I apologize that we are being cognizant, but running over time. So we will capture all the questions and make sure we address those in the next webinar. But Ryan, myself, and some others, we will be in Seattle all weekend for the International OCD Conference. So if you're in town and here, please come catch us at the booth. If you're watching this on YouTube later, of course, we'll see you next time that we see you, or maybe we'll cut that out. But thank y'all for attending. As always, we appreciate you taking your time because it just shows your commitment to learning and doing appropriate evidence-based care.